Dr. Krishanu Das is a consultant urologist, uro-oncologist, and laparoscopic surgeon who has been working with us in Bahrain Specialist Hospital for 3 years. He obtained the training in several APEX centers around the world, including India, UK, Europe, USA, and Australia. His key areas of interest are endourology, minimally invasive surgeries, and laser surgeries. He's going to talk today on current practices in surgical management of benign prostatic hyperplasia. So we are in for a great talk. I will be handing it to Dr. Das. Please ensure your microphones are muted for the duration of the talk and note down any questions for the Q&A sessions afterwards. Please, Dr. Das. Yeah.
Thank you, Dr. Bashar, and very good morning to everyone, and hope all of you are staying well. Today, I've chosen this topic of surgical management of benign prostatic hyperplasia in current practice, the good, the bad, ugly. It's mainly because of the current situation with prostate, which is one of the commonest ailments we get in urology practice. I do not have any financial disclosures or conflict of interest. While preparing this talk, I have taken help from the current guidelines of the American Urology Association, the European Association, the Canadian Urology Association, our latest Campbell-Walsh Urology, which is considered the Bible of urology to us urologists, and literature search. To start with, benign prostatic hyperplasia, the definition goes as per a histological diagnosis. So it's a histological definition, and it is associated with unregulated proliferation of connective tissues, smooth muscle, and glandular epithelium within the prostatic transition zone. We must remember prostate gland has got two key components. It's got a glandular element, which has got secretory ducts and acini, and a stromal element, which has got collagen and smooth muscle. There are two phases of this obstruction, which is dynamic obstruction, which is mainly due to the smooth muscle tone. And the other component is the static obstruction, which is due to enlargement of the prostate. This is a mechanical obstruction. So there are two stages in which the benign prostatic hyperplasia, the prostate nodules grow. The first stage is definitely growth of nodules in the periurethral zone, as you can see up in the pink shade. And then subsequently, there is significant increase in size of glandular nodules. Before we proceed, we will be getting a few terms, and we just want to clarify. This is one of the Hertz diagrams, and this is very important for understanding. We all men more than 40 years is the main age where benign prostatic hyperplasia starts. So a certain proportion of us will develop BPE, or benign prostate enlargement, which is a medical term to describe prostate enlargement. Another certain proportion of men will be developing bladder outlet obstruction, which is a diagnosis based on urodynamic investigations, which is characterized by high detrusor muscle voiding pressure, poor flow, with or without a high post-void residue. A significant amount of people will also experience LUTS, or lower urinary tract symptoms, which is a constellation of symptoms triggered by obstruction, abnormality, infection, or irritation of the urethra, bladder, bladder neck, urinary sphincter, and or prostate. It doesn't necessarily have to be a benign prostatic hyperplasia to cause LUTS symptoms or bother. There is considerable overlap between these clinical terms, and as we proceed, we will see how they are. Why we are discussing about benign prostatic hyperplasia? As Dr. Bashar rightly mentioned, we do get this problem in early 40s also. And in people or men aged more than 50, it ranks amongst the fourth in the terms of prevalence for medical diseases. This is a life expectancy and the population chart which I took from the United Nations, and we can see even in 2005 we have a growing population and we have increasing number of people above 65, and life expectancy is increasing. So what it means is the load of benign prostatic hyperplasia to us is constantly on the rise. An older data from the US recorded of almost 27 million men of ages more than 50 suffering from BPH or benign prostatic hyperplasia. Contrastingly, the awareness of prostatic hyperplasia is very little in men, and this is from the survey, European survey, which was published in 2019. Going to the risk factors, the non-modifiable and modifiable risk factors. The age, geography, and genetics are the non-modifiable, and the modifiable are hormones, metabolic syndrome, obesity, diabetes, diet, physical activity, and inflammation. These interact through various pathways to increase the sympathetic tone, and this results in increased growth of prostate, voiding dysfunction, and also at the same time we do get erectile dysfunction in the same group of people. This is very important to understand. Right from the age 40, the histological BPH starts and it progressively increases as we get older. The prostate grows about 2 to 2.5% per year. IPSS, which I will elaborate later, is a symptom score which increases by 0.18 points per year, and the peak flow rate decreases by 2% per year. Of note, 34% of US men and 29% of European men aged 50 to 80 years reported moderate to severe lower urinary tract symptoms. Lower urinary tract symptoms are also an independent risk factor for sexual dysfunction in aging men, and both of them may impact the quality of life. This is a very important diagram, and this shows as we get older, almost all the parameters, the prostate size, the symptoms, the quality of life, the bother, the peak flow rate, everything changes. So as we can see, from 40 to 49 to 50 to 59, all the bars go up as we get older. And this data includes several countries, not only the US. So it's a worldwide data and a very important thing to understand. Interestingly, one of the French studies showed that the mean age of patients who receive medical treatment are coming down. So they have decreased from 69 to 68 years, and there was a 24% increase in the use of medical therapy. And this data came from 2013. So, you know, in current days, we'll have even younger patients coming and seeking help for benign prostatic hyperplasia. Those who are seeking surgical treatment also decreased from 71.5 to 69 years. Now, the prostate, as we know, has got two main lobes, which are the lateral lobes and the median lobe. The growth of prostate can be symmetrical or asymmetrical. We can have a completely submucosal adenoma. We can have a median lobe causing a ball valve effect. We can have the lateral lobe progressively growing into a median lobe, and all these will impact the type of symptoms the patient presents. So what problems we are facing due to enlarged prostate? It leads to bladder outlet obstruction and leads to lower urinary tract symptoms, acute urinary retention, urinary infections, hematuria, bladder stones, and renal insufficiency. Collectively, LUTS includes a number of symptoms. So these are mainly storage symptoms, which categorized into frequency, urgency, nocturia, and incontinence. Voiding symptoms are usually hesitancy, straining, weak stream, intermittency, incomplete emptying, and post-micturition dribble is also often complained by the patients. How do we assess these patients? So definitely the clinical history is very important. IPSS score is a very important tool in these, and we routinely follow this for all our patients presenting, and we grade the scores based on the least bother and the most bothersome, and the score rates of 1 to 7 is mild, 8 to 19 is moderate, and 20 to 35 is severe. A rectal exam is most important in assessing the prostate health, the size, the tone of the anal sphincter. And then we do advise frequency volume charts. There are 3 types of charts, and most commonly we are using a frequency volume chart. However, the other ones are micturition chart and bladder diaries. What we do record is the voided volume and the time of micturition during day and night for 24 hours. It's usually a 3-day chart which the patient brings to us. Bladder diaries are more extensive, and they also give fluid intake, incontinence episodes, degree of incontinence, pad usage, and degree of urgency. Investigations are mainly urinalysis, which is advised in all patients, cytology only if good history of smoking, heavy smoking, severe storage symptoms, dysuria is there, then we advise. PSA, as per the current recommendation, is only advised in men with life expectancy of more than 10 years. Creatinine is, as per the EAU guidelines, the European guidelines only, they have suggested to do a routine creatinine, or if you are getting a patient with renal impairment or prior to surgery, these are the scenarios where creatinine is advised. An ultrasound with a post-void residue is mandatory on all patients to understand the prostate size, the impact on the bladder, the residue urine which is there. Uroflowmetry is usually recommended before active treatment. Urodynamics, which includes filling cystometry and pressure flow studies, have their own indications, and occasionally we will proceed with a urethral cystoscopy, especially if we are meeting a patient with gross hematuria or with a history of bladder cancer, recurrent urine infection, previous prostate and urethral surgery. Very important to understand that as the prostate volume increases and the baseline PSA increases, the risk of urinary retention also increase. So that is why it's very important to understand the baseline PSA and the baseline prostate volume to help the people, to counsel the people, to make them aware that these are the candidates who run the risk of urinary retention. Urodynamic study is the gold standard for the assessment of lower urinary tract symptoms, and it can identify detrusor overactivity, detrusor underactivity, low bladder compliance, and bladder outlet obstruction. Pressure flow studies have special indications, and usually we perform them only if there is a previous unsuccessful invasive treatment for LUTs, patients who cannot void more than 150 mils, or patients with a large post-void residue more than 300 mils, where we are concerned with the detrusor muscle function. Patients who are very elderly or very young with predominantly voiding LUTs, they are also candidates for having a urodynamics. The treatment options include watchful waiting, medication, and in-office therapy or surgery, which are both coming into the category of interventions. Watchful waiting mainly includes lifestyle measures. I don't want to go into details of this, but it's mainly on education, reassurance, adjusting the caffeine alcohol intake, types of toilet retraining, bladder retraining, and these ideal candidates are uncomplicated benign prostatic hyperplasia, symptoms which are not bothersome, which is a classical IPSS score of less than 7. And also sometimes patient chooses to avoid treatment even if with bothersome symptoms, and we can always try watchful waiting to start with and then proceed to other therapies if they are not responding. Pharmacotherapy, I don't want to go in details, but the most commonly are alpha adrenergic blockers and the 5 ARIs, which are used most commonly. Phosphodiesterase type 5 inhibitors are also used nowadays very commonly for these situations, and they are working in different lines. The alpha blockers mainly relax the smooth muscle. The 5 alpha reductase inhibitors reduce the prostate volume by PD5 inhibitors have a significant role and currently widely used for management of benign prostatic hyperplasia, and they work by multitude of mechanisms. The most commonly used in practice are the combination, and you can see as the symptoms increase, they are widely used. Of course, those with severe symptoms and not responding to treatment usually lands up into surgical treatment or interventions. This is also the right side, the cartoon shows the biggest benefit is always with a combination than either the alpha blocker or 5 alpha reductase individually. So this reduces the risk of progression. There are many plans or many algorithms of managing prostate symptoms, and this is just one of them. And very simply, if they're mild symptoms, we usually go for watchful waiting. Moderate symptoms with erectile problems, we go for alpha adrenergic antagonist, alpha blockers, PD5 inhibitors, or both. Small prostate with a low PSA, usually an alpha blocker. Larger prostate with increased PSA is usually 5-alpha reductase or a combination. And if there are irritative voiding symptoms, we have to resort to anticholinergic agents. However, when the symptoms are severe and complications of BPH, then we proceed to minimally invasive surgery or prostatectomy. And this is the key area where we will be talking more today. Who are the candidates who are at higher risk for clinical progression? Those with a higher PSA value, those with larger prostates, and those with a greater postbiotic. There are other pointers also to decide who are the candidates who will eventually need surgery. Those with severe symptoms. So as the severity of the symptoms are more, they usually progress to surgery. And the force of stream, if the stream is very poor, they do very poorly with medications and they will need to switch over to surgery. So indications for intervention include bothersome moderate to severe lower urinary tract symptoms, refractory to pharmacological treatment, refractory urinary retention, recurrent urinary tract infections, recurrent or persistent gross hematuria, urinary bladder stones, renal insufficiency secondary to BPH. This is a rough schematic of how we developed the surgical treatment of prostate. So the open prostatectomy was mentioned right in 1900. So, this treatment has been there for quite some time. 1970s, there was quite a bit of excitement actually from 60s to 70s about TURP, which is considered one of the gold standards in management of prostate. 1993 witnessed the evolution of thermotherapies. 1995, vaporization techniques. 1996, the laser prostate surgeries came in vogue. 2002, the technique of laparoscopic simple prostatectomy was described, and 2004, we had the advent of prostatic urethral lift. 2007, the first robotic simple prostatectomy publication came over. So TURP, or transurethral resection of prostate, as per the 2003 AUA guideline, recognized that this is the benchmark for therapy when we consider interventions. And this was mainly because of the high success rate with symptom scores, urinary flow, post-void residue, and low retreatment rate on long-term follow-up. However, there are multiple complications which have been observed after TURP, which includes perioperative bleeding, blood transfusions, transurethral resection syndrome or TUR syndrome, which is mainly a dilutional hyponatremia, prolonged catheterization, long hospital stay, urinary incontinence, and retrograde ejaculation. So as a consequence, various other alternative surgical techniques started to be developed to find and reduce the complications of TURP, but keeping the same efficacy. This is how a standard TURP is done. It's completely done through the urethra, transurethral, and we use monopolar current. What we are describing is a monopolar TURP, and this is how the current pathway flows from the loop, which is the cutting instrument, to the tissue, the body, and to the indifferent electrode. Few things we are going to mention about TURP, and it's most important to understand that TURP, since its evolution, has undergone many changes, which includes optics, light sources, anesthesia techniques, surgery techniques, bipolar technology, use of physiological solutions. With evolution of medications and minimally invasive techniques, the number of TURPs have also decreased from 1981, considering 229 to 268 per 100,000 people, to 1994, where it was 131 per 100,000 people. Again, in 1999, it ranged to 81% of BPH procedures, and in 2005, it was only 39% of the BPH procedures. TURP has good success rates. 75 to 93% patients are satisfied after surgery. And TURP in anticoagulated patients, there's significant risk of bleeding. We'll address this in the subsequent slides one by one. So These are few charts which show the diminishing role of TURP as the other techniques catch up. And the bottom slide, the TURP is on the top, and you can see a progressive decline in performance of TURP, whereas the other techniques like lasers or vaporizations have been on the increase. TURP has good success rates, as we mentioned, and the overall success rate is quite good. This is a long-term result of randomized control trial, and you can see quite good results from TURP in comparison to the other types of techniques. And sexual dysfunction after TURP has been a boiling question, and we can see that if a patient has good erectile function pre-TURP, the preservation of erectile function is significantly good. And even with patients with mild or moderate pre-TURP symptoms, about 16% had improvement of erectile function after TURP. This could be due to improvement of the LUTs. TURP is not particularly directed to improving a sexual function other than restoration of the patient's quality of life. Coming to anticoagulants, TURP has a highest risk compared to other techniques about the bleeding, the transfusion requirement, clot retention, secondary coagulation, revision, and secondary hemorrhage. And depending on the type of anticoagulant, there are several protocols as to how to proceed. When we have warfarin, minimum 5 days of stopping, switching over to low molecular weight heparin. When we have a patient on aspirin, it's better to stop a week before and then restart 48 hours if adequate hemostasis is achieved. And then when we have patients taking clopidogrel, we have it's better to cease a week before and recommence after 48 hours. Newer techniques from the conventional TURP, which was monopolar, is a bipolar TURP, and the principle is the same here. The instrumentation has two active electrodes. So what happens is the current flows from the active to the passive electrode instead of passing through the body, and less chance of having nerve injury and other side effects. These are different types of instruments for performing a bipolar TURP. And surgeons prefer to operate on larger prostates using bipolar technology because of the safety, less bleeding, and less chances of dilutional hyponatremia. And it is a strong contender to replace the monopolar TURP as the new gold standard. Overall adverse effects were much less from bipolar than monopolar TURP, and this was a review of complications from 1997 to 2007, so almost 10 years of review of complications, and it showed that lower rates of bleeding, transfusion, time with catheter, continuous bladder irrigation need, hyponatremia, and TUR syndrome were much less with bipolar TURP, and less capsular perforations and less operative time. In terms of efficacy, because it's very important to see both sides, the adverse events and the efficacy. So Qmax, which is the peak flow, which is almost equally preserved with monopolar and bipolar, marginally better with bipolar. The IPSS score, which is again the symptom score, was also significantly, I won't say there was no level of significance reached, but it was almost equally comparable between the monopolar and the bipolar techniques. And the post-void residue, which is also very important, was slightly better with the monopolar, but these data have been constantly updated. We do get better results as time proceeds. Alternatives to TURP, as we know, we need to have better techniques to reduce complications, and that's why these have come up. We have endoscopic surgeries, we have non-endoscopic surgeries, and we have minimally invasive treatments. Endoscopic and non-endoscopic surgeries are usually performed under anesthesia and usually for patients fit for anesthesia. For minimally invasive therapies, they are performed without anesthesia as office procedures and usually for patients who are at high operative risk, not fit for proceeding for any surgery. Endoscopic surgery, which are alternatives to TURP, there are two main types. One is transurethral vaporization of prostate and transurethral incision of prostate. Laser surgeries, which are very much in talk nowadays, which are called three types are used: coagulative laser, cutting laser, and vaporizing laser. I'll be elaborating these in the subsequent slides. So firstly, the vaporization technique, and this vaporizes and desiccates the prostate. Exchange of the resecting loop with an element of large surface area. So the TURP loop, or the instrument we use, is a very thin loop, and when we change it to a element with larger surface area, this is what we get. We get vaporization of the tissue, and this has got a short learning curve. This is high vaporization speed, excellent hemostasis, and virtually bloodless procedure. When we compare these two techniques, because every technique we have to compare with TURP as it was considered as the gold standard. So the improvement of symptoms was better than TURP. Clot or evacuation and bleeding was less than TURP. However, recatheterization rate, need for retreatment, postoperative dysuria, new onset erectile problems were more in the vaporization group. 2 cases of unusual complications have been reported where urethral necrosis and bladder necrosis were reported. Fortunately, they have not been seen in other series, but needs to keep in mind. And usually vaporization works for smaller glands, 50 to 60 grams, whereas a TURP can be used for larger glands as well. In transurethral incision of prostate, this is probably even earlier than TURP, which came, and the first mention was in 1834. And it is usually ideal for a young man with a small prostate, less than 30 grams, who is concerned about loss of ejaculation or future fertility. And by this technique, we disrupt the prostatic capsule and alleviate voiding symptoms. Small cuts are made at 5 and 7 o'clock position, and the prostate tissue around the urethra springs apart, making it easier to pass urine. When we compare TUIP with TURP in randomized data with similar age profile and similar prostate size, it was noted that TURP has more retrograde ejaculation, whereas TUIP has less blood transfusion than the TURP group. However, the symptom scores in this particular profile of people, there is no difference either in their symptoms or their flow rate or the detrusor pressure after few months. Coming to laser treatment, and this is currently one of the highly recommended treatments for management of BPH. This is a treatment where light energy is converted to thermal energy, and as you can see, the NICE currently is recommending highly the laser treatment for prostate, and laser prostatectomies are on the rise. This is a New York State data right from 2002 to 2011, where you can see a significant rise in laser surgeries being performed. More data from other countries where we can see that TURP performance has been almost the same, whereas there has been rise of performing the HOLEP or the holmium laser enucleation of prostate. KTP remains almost the same over years, or probably slight decline. Maybe it is related to the particular preference in that zone. The bottom slide is from Canadian data, and this is also showing increase in the number of laser procedures per procedure for BPH over years between 2007 to 2011. So what is laser treatment for BPH is basically an acronym of light amplification by stimulated emission of radiation. The 2 basic principles of laser therapy, and this includes laser coagulation and laser vaporization. In coagulation, we are using a low density laser thermal energy to produce tissue coagulative necrosis, and we are achieving delayed anatomical debulking. Whereas in vaporization, which is more favored nowadays, is high density laser thermal energy is used to produce vaporization, and coagulative necrosis also occurs in the adjacent residual tissue. Finally, we have an anatomical deobstruction and the urethra opens up. So coming to laser vaporization, which is practiced more nowadays than coagulation, there are 3 techniques in that. Coagulative laser, which is the neodymium YAG laser or the diode laser, commonly practiced as the diode. Cutting laser, these are very much in use. Holmium laser and thulium are these types. And vaporizing laser is usually the KTP and diode, which are very much in use. The lithium borate is also used. mostly. What are the advantages? Minimal blood loss, shorter hospital stay, high success rates, 88% respond to treatment immediately. There is good urine flow improvement immediately. One of the major benefits of lasers are for cardiac patients on blood thinners, renal failure patients with bleeding diathesis, patients with comorbidities. A laser surgery is very good because it can be safely performed. Another advantage is the gland size. The prostate gland size can be anything, especially with holmium and thulium. We can operate on really larger glands without having any fear of having any side effects, major side effects. So the holmium laser is used mainly for enucleation of the prostate. The KTP or the green light is mainly used for vaporization. Diode is mainly used for vaporization of the prostate, and thulium laser, which is a newer type of laser, can be used both for enucleation, vaporesection, and vaporization. Most of these techniques are compared to TURP, and you can see the maximum comparison are maximum number of studies are between the HOLEP and the TURP. And what we can see is the prostate volume, the resected weight, the catheter time, and the hospital stay were all favorable in terms of holmium laser. And these are significant number of studies, and most are, you can see, 2004 to 2007. So currently even randomized studies have even better results. Comparison between green light and TURP, we had significant benefit with the surgery time, especially with green light and the catheter time. All the lasers have the chief advantage of getting rid of the catheter early, which is one of the big advantages of laser. Hospital stay also is much less than in TURP. There's only one study in this group between TURP and thulium laser because it's a much newer laser, and the resected weight was significantly different. Catheter time and hospital stay again was favorable, as was seen in all the lasers. When we compare between the three lasers, it's important to know that with holmium and thulium, we can obtain tissue for histopathology. It's very important because we need to know whether there is any cancer foci inside the prostate we take care of. KTP doesn't have this, so if a patient has high PSA and we have suspicious, we have to do a prostate biopsy separately before taking for KTP laser. The learning curve for holmium is steep. KTP is a much easier learning curve and much more favorable. Holmium, however, requires extensive training. Thulium also requires same learning curve as holmium laser. The gland size in holmium and thulium can be, larger glands can be tackled, and holmium laser has been tackled for very large glands where previous days only open surgery was offered. The symptom score amongst the three lasers, the best was achieved by holmium laser, and this was much better than TURP. Others have also good symptom score and flow rate improvements, but the best outcome was seen with holmium laser. Intraoperative complications like bladder injury, urethral orifice injury, capsular perforation are almost similar, all of them. Postoperative complications for holmium, because it is an enucleation technique, retrograde ejaculation is more common, whereas KTP or green light, because it is depending on vaporization, dysuria, urinary tract infection, epididymitis, urethral stricture, these are more common. Thulium, the more common side effects are recatheterization, reoperation, hematuria postoperative. Let's come to the non-endoscopic surgeries, and the most important here is prostatectomy, which can be done by the open technique, laparoscopic or robotic. And we can see there is a progressive decline in performing these surgeries because of the lasers being available. So practically the numbers are going down. What are the benefits of them? Advantages are lower retreatment rate, more complete removal, and once again there is no risk of dilutional hyponatremia or TUR syndrome. This is important because previous days the TURP, large number of patients were facing this, and they would require ICU admission and intensive monitoring post-operatively. Disadvantages are, of course, a lower midline incision for an open prostate, and even for the minimally invasive prostatectomies, you have to take out the prostate. So you'll need a small cut and you need a few access. Usually 4 to 5 ports are what we use both for the laparoscopy and the robotic techniques, and it requires definitely a longer hospitalization and increased perioperative hemorrhage. Coming to minimally invasive techniques or minimally invasive treatments, collectively called MIST, and you can see they are somewhere in between the medical management and the definitive therapy, both in terms of invasiveness and their effectiveness. What are their indications? When there is a moderate symptom score or severe symptoms, but the patient is unfit for major surgery, like they have heart failure, myocardial infarction, liver disease, pulmonary disease, neurologic diseases. Where we can't perform MIST is recurrent hematuria, recurrent urinary retention, bladder stone, BPH, upper tract dilatation, bladder diverticulum, or if the patient has renal failure, recurrent urinary tract infection, implanted pacemakers, penile prosthesis or artificial urinary sphincters, urethral stricture, or there is a metal implant in the pelvis. What are the different types of MIST? So we have devices for delivery of thermal treatment or thermotherapy, where heat is applied to the prostate, causing tissue necrosis and sloughing, and the obstruction is relieved by decreasing the bulk of prostate. So there are 4 techniques within this: microwave therapy, radio frequency thermotherapy, which is called a TUNA, microwave is TUMT, which has prostatron, Targis, Cotherm, various names. HIFU, which is also used for prostate cancer also, and transurethral water vapor therapy called RESM. This is currently very popular in Canada and very widely practiced. Then we have mechanical devices which maintain urethral patency using specific designed devices, in which we have the prostatic stents, we have the prostatic urethral lift. This is also very widely used. I will tell why the advantages are in the subsequent discussions. And temporary implantable nitinol device, which is also commonly known as the TID. Fractionation of prostatic tissue using high intensity energy through is another technique where we cause tissue emulsification without thermal effects. And the techniques here are histiotripsy or aquablation using water jet hydrodissection called aqua beam. Then we have percutaneous approaches where a good interventional radiologist can help by embolization of the prostate artery to hinder growth and induce apoptosis. And this is commonly popularly called PAE. We have transurethral balloon dilatation of prostate for very moribund patients who are not fit for other procedures. And intraprostatic drugs are also employed to help BPH symptoms, where they can reduce the prostate volume by inducing apoptosis, tissue necrosis, or they can also prevent the afferent nerve signals and alleviate obstruction and improve lungs. So first, the thermotherapy, the TUMT or microwave therapy, is where we give locally thermoablate prostate tissue while maintaining normal temperatures to the surrounding non-targeted tissue, and the dose should be confined to prostate with minimal or no heating. This is what is the ideal recommendation, so that the surrounding structures are protected from heat-induced necrosis. And this is how it is performed. TUNA or transurethral needle ablation is where a radio frequency flows into the prostate parenchyma, which interacts with the water molecules in the cells, and this leads to localized heat around the needles, and it causes a spheroidal area of coagulative necrosis, which later undergoes cavitation. HIFU uses a focused ultrasound beam which induces rise in temperature. Transrectal probe is used. Prostate gland retains its general anatomic configuration in this technique, but it shrinks to a small size over 3 to 6 months of therapy. And this is usually how it is performed. Comparing outcomes, we have, when we compare with TURP, we have good decrease in symptoms in the initial phases. And you can see both the symptom score and the flow rate are decreased about not exactly as much as TURP, but reasonably at the beginning. Adverse events mainly are prolonged postoperative retention, mild hematuria or urinary retention, bladder neck stenosis, urethral stricture can be noted with HIFU. The most important drawback is retreatment. A significant amount of these patients will require further treatment, and they are usually applied for cases who are not fit for other definitive treatment. Satisfaction rates are fairly equivalent at 3 months, but as time goes, the outcome from TURP is superior because the treatment is never complete in these cases. Prostatic urethral rift or urolift device is again one of the very common devices performed currently, and there are particular implants which are called polyethylene terephthalate implants, and they are non-absorbable monofilament implants which are usually used like a stapler through the urethra into the prostate, and the whole purpose is to keep the prostate in hold, keeping the passage outlet wide open. Depending on the size of the prostate, we can apply single, multiple staplers, usually 2 rows if it is a larger prostate. Most important to understand that it will treat the lateral lobes of the prostate, but it is not appropriate for median lobes. So those patients who have a median lobe, this technique is not to be applied. And this advantage is low voiding symptoms and minimal sexual side effects, minimal erectile function change, and minimal changes to ejaculatory function. RASM is again currently many YouTube videos will be there and widely popularized in Canada, and it is utilizing radio frequency power to generate thermal therapy in the form of water vapor, which is injected transurethral into the transition zone, which causes a cell death and tissue necrosis in a spherical ablative lesion of 1.5 to 2 centimeter. This is how it looks before and after. So there is a shrinkage of the prostate due to ablation. Benefits are it has got a favorable safety profile, low retreatment rate, can be used as office or outpatient procedure, and again preservation of sexual function is a key benefit from this RASM treatment. Outcome, you can see 35 to 45% prostate volume was reduced over 3 months, and there's significant change in the symptom score, and the peak flow rate also improved over time. This is one of the real life experiences. It's very, very common recent technique. So you can see this is from a 2018 article. Prostate artery embolization is again one of the newer techniques, and it is attempted by a good interventional radiologist. This is one of the studies published in BMJ very recently, and what it shows is there was significant improvement in lower urinary symptoms similar to TURP in this population of patients who underwent this procedure. They had moderate symptoms to start with, and the difference of symptom score between the TURP group and them were almost the same, with fewer complications. In terms of complications, the prostate artery embolization had all favorable complications except for immediate postoperative pain, and of course the hematuria, urinary incontinence, urinary tract infection strictures were much less with this technique. Intraprostatic injections are usually used in certain scenarios where other treatments are not applicable, and they can both affect the static and the dynamic effect. The static is mainly by reducing the creating apoptosis, and there are several agents used in that. And for the dynamic, the smooth muscle tone can be changed by using a botulinum toxin. Transurethral balloon dilatation of prostate is another technique, and this is where a balloon is used forcefully to create a capsular break or capsular tear so that the pressure inside the prostate is released. Of course, these techniques are used for patients who are not fit for other procedure, and they are all short-term benefits. Now let's come to our main point of discussion as to how to choose what to do in these patients. What are the guiding factors? I usually consider 3 main factors very important in these cases. One is the patient factors like patient comorbidities, if the cardiac patient, renal failure, bleeding diathesis, the patient's fitness for anesthesia, if they're fit or unfit, and of course we have to listen to the patient what they prefer, because everyone should be given a clear idea of all the options available. Anatomical factors include the size of prostate, whether there is a median lobe present, or whether there are other pathologies along with a prostate enlargement like stones, bladder tumor. Ancillary factors also depend on surgeon's experience, available treatment options in the local facility, and of course the expenses with the procedure, because many times the patients are paying for these procedures. Finally, the efficacy and the adverse events are also very important in choosing what type of procedure to be done. Let's go by the guidelines. So the guidelines, this is the American Urology Association guidelines, which is and this guideline divides the treatment decision based on gland size, impact on patient function, and whether the patient is on anticoagulants. So if it's a large prostate, the recommendation is usually simple prostatectomy, holmium laser, enucleation of prostate, and thulium laser enucleation of prostate. If it's an average prostate size, right from aqua ablation, holmium laser, green light, prostatic urethral lift, TUMT, TURP, water vapor thermal therapy, all can be applied. If it's a smallish prostate, then aqua ablation, TUIP, which is the incision technique we talked about, TURP, vaporization, water vapor thermal therapy, all can be applied. What are size independent options? They are both the lasers, any size of prostate with good safety, we can deal both the holmium and the thulium laser. And patients who want to particularly preserve their erectile and the ejaculatory function and don't want a major procedure can be offered prostatic urethral lift or water vapor thermal therapy. Patients on anticoagulants, the lasers are mainly need to be used. This is the European guidelines, and here again the categorization is based on patient comorbidities, anesthesia fitness, patients on anticoagulants, and prostate volume. So we have high risk patients, whether they can undergo anesthesia, whether they can stop coagulation, anticoagulation, and what is their prostate volume. Based on that, the choice of the procedure is pretty much dependent on that. Smaller prostates, TUIP, middle-sized prostates is usually a TURP, and bigger prostates, a holmium laser. And whenever the patient cannot stop anticoagulant, is usually laser technique. The Canadian guidelines also the same, almost like the European guidelines, there's no changes. Let's see the efficacy, how to decide which technique. So when we compare all these techniques, this is from the current practice guidelines from the AUA or American Urology Association. What we see is HOLEP has the maximum benefit compared to the monopolar TURP, which was considered the gold standard, and HOLEP in current days is giving the best results. Green light also has a good benefit in terms of a decrease in post-void residue, and the symptom score and prostate volume decrease, however, is the lowest with the green light, and this is one of the reasons where the popularity of green light is not very good. However, we have bigger wattage machines. The 180 watt machine, this study was based on the 120 watt machine, and the 180 watt machine promises treating bigger size prostates. In terms of comparison of efficacy in terms of symptoms, we can see as the number of years go by, medical management, minimally invasive treatment, and surgical management is always best in terms of long-term efficacy, both in terms of improvement of symptom score and improvement of the flow rate. Let's talk of adverse events, and this is also very important in choosing a procedure. And you can see if there is transient urinary retention or urinary tract infection is most common with the microwave therapies. All the major complications, bladder neck contracture, urethral stricture, incontinence, blood transfusion, clot retention, postoperative hematuria, these were more commonly seen with monopolar TURP. Irritative symptoms, dysuria, urgency, storage symptoms, more commonly with the microwave therapies. Reoperation for benign prostatic enlargement, this is more commonly seen again with microwave therapies. Also higher with green light laser, which has been reported, but these are mainly for low power lasers. So my take home message for today, the good, the bad, and the ugly in this choice of procedures. The good, if the patient is fit and resources are available, a bipolar TURP, the patient is on blood thinners and not having a large size prostate, then obviously a holmium or a thulium laser. Green light can also be an option depending on availability and the size of prostate, but these three lasers are principally to be considered when the patient is on blood thinners. The patient is not fit for major surgery, or patient wants a minimally invasive procedure, a Urolift or Resum would be the ideal choice. The bad monopolar TURP, usually the gold standard, but currently we have to consider it as bad because a bipolar is giving better results. So it's a bit harsh, but with newer techniques, monopolar has gone into worse technique. Monopolar TURP, TUIP, depending on the gland size and vaporization techniques, if small prostate. Laparoscopic robotic prostatectomy, they are good, but they are sometimes overkill for doing a large prostate, especially with the availability of the lasers. TUMT and TUNA also fall in this category. Ugly at this time in my consideration would be open prostatectomy, prostate stents, intraprostatic injections, and transurethral balloon dilatation of prostate. This is a current analysis, and this is showing a future prediction of market analysis. And we can see as time is progressing till 2026, laser surgeries are going to capture the market in big way. Prostatic urethral lift is also taking a sizable share of the market, and the others are there. TURP share of the market is progressively going down. Currently, we are offering these services, which include the monopolar, the bipolar, the transurethral incision of prostate. Of course, we can offer laparoscopic prostatectomy, which I have not included because it's not one of the recommended ones. The high power holmium laser is what we got in our armamentarium for almost 1.5 hours now, and we are happy. We are offering it to quite a large number of patients, and currently we have the 140 watt machine, which is doing quite good for significantly comorbid patients, and we have good results. And that would be thank you for your attention.
Thank you very much, Dr. Das, for the detailed and informative session. I will hand it to the audience. If anyone has a question, please type it in the question and answer session or raise hand. A question from Dr. Abdulaziz Mohammed. What would be the ideal technique for patients on dual antiplatelets or anticoagulant?
Do we answer here?
Yeah, please. Yes.
Good morning. Good question. So patients on dual antiplatelets or anticoagulants, my preference of choice is a holmium laser enucleation of prostate if the resources are available, or thulium laser. They are the two best to be considered in these situations. We have been doing patients with antiplatelets also, and they are significantly with the laser. That is the biggest advantage of lasers, is we can do the procedure with patients on these medications.
Yes, any other questions? During they prepare their questions, Dr. Daz, I have a question for about preserving sexual activity. Yeah, eligible patients who desire to preserve erectile and ejaculatory function. From the data, what procedure indicate greater preservation of sexual function?
So, in terms of sexual function, the most beneficial are the minimally invasive techniques. So, as per the current assessment of the whole literature, all the published studies, prostatic urethral lift and Resum, these are the two best when it comes to preservation of sexual function. They are both minimally invasive, and if the patient has a reasonable size prostate, of course between 60 to 80 grams, and not having a median lobe, my choice would be a prostatic urethral lift, which is very easy to perform. We have been performing this largely in Australia. It's very much into practice and very easy technique. Unfortunately, we haven't got this here yet, but we are looking forward to introduce this one.
But the patient has to accept retreatment.
With the prostatic urethral lift, retreatment rates are very less.
Or less.
Yes. The microwave therapies, they are the ones where the retreatments will be required.
For the audience, any question, please? Yes. This is from Dr. Alden Precious, our colleague. How deep is HOLEP tissue resection? Is there any chance to perforate prostatic capsule? Excellent lecture, and thank you, Dr. Das.
Thank you, Dr. Alden, for your question. It's a very important question, and definitely HOLEP has got high risk of perforation of the prostate capsule. So that is why the learning curve is very steep, and it needs, when I say the learning curve is steep, it needs minimum 30 to 40 cases or maybe up to 50 cases also to learn a good HoLEP. So it is all dependent on how or when the training has been, but if we understand the plane and we keep the plane in consideration, we can tide over. The most important is the irrigant used here is normal saline, which is a physiological saline. And if there are minor capsular perforations, we may tide over without having any major consequences. It's not like the monopolar TURP where we are using glycine and there is risk of dilutional hyponatremia. So capsular perforations are one of the most common complications for HoLEP, requires mastery with the technique. But despite having capsular perforations during HoLEP, patients' morbidity is not much.
Thank you, Dr. Das. Thank you. Any other question? Thank you all for your participation, and thank you very much, Dr. Das, for a great lecture.
I would like to thank the entire BSH team, the higher management, the marketing team, and all Dr. Bashar and all the concerned authorities who gave me this opportunity to talk on this topic. And we are happy to help you out. For those who want to refer patients, we are very happy to help you out with your patient suffering from BPH. Thank you. Have a good day.
It has been a pleasure to moderate this event. Thank you. I hope everyone has a great day ahead. Thank you very much. We can conclude. Thank you.